Okay, so in approaching this topic, this question, I sort of framed it with this. What are some real-world opportunities for research involving older adults with concomitant illness and polypharmacy? And the example I draw from is, in my career, I have had to sort of sell clinical pharmacy to health systems for the last 30 years or so. And anytime I come in and say, hey, there's this tremendous evidence for the value of pharmacists in improving medication safety and outcomes, here's the evidence. If I then say, I need you to modify processes X, Y, and Z in your operation to accommodate, well, the front office staff is going to change the locks and never let me back in. It doesn't work that way, right? The important thing is to align with what the system is already doing. And if you do that, then you'll be successful in incorporating new programs such as clinical pharmacy services. So in that same vein, as I approach this question, thought about the work that we do where we're basically aligning with where the seniors are anyway, where they're going, where they're patronizing. And so the two examples I was going to share are PACE programs and community pharmacies. I don't think I need to redefine PACE for everybody on this call. I think most of you are very familiar with PACE and the tremendous amount of services that are offered through a multidisciplinary team. Partial listing you see here, just about everything in terms of care, both social and health for beneficiaries of PACE services. That really creates a nice environment, very safe environment to do things such as clinical trials. In my specific example, we received a Center for Medicare and Medicaid Innovation, Healthcare Innovation Award that we just completed a couple years ago, where we integrated clinical pharmacy teams into the largest private Medicaid provider in the nation, AltaMed Health Services. We had mostly live teams. We had a telehealth component. We had a PACE component that was added in year 2 of this 3-year grant. Expanded trainings for residents and technicians, created online training for pharmacists, and no surprise, the outcomes that we had were all quadrupling maligned. We found that AltaMed, and I'm sure this is common with most of the PACE centers, did a remarkable job of improving general safety for the PACE recipients or beneficiaries that they took care of. For example, they would go out to the patient's homes and do a thorough inspection of fall risk and actually make changes to the home to make sure that they would minimize such risk. Even before we came on board, their ability to drive down ER visits and hospitalizations was really impressive. But we did conduct this evaluation. We're able to show that by having a pharmacist involved in comprehensive medication management, we were able to drive down further both emergency room visit rates and hospitalization rates. The data that you have in a PACE program, and Jonathan knows this, he mentioned he worked in a PACE program, it's very robust. And again, having so many disciplines involved in ensuring the safety of the participants in PACE programs just makes it a very nice environment for clinical trial research. The other group that I said I'd mention are community pharmacies, and I don't know how many of you on this webinar have worked with community pharmacies in clinical trial research, but for the longest time, there was an often cited data source that said the average American visits their physician 2 to 3 times a year, but visits their pharmacy 2 to 3 times a month. And that's a huge disparity. That's a lot of face time, isn't it, in the community pharmacy? But that was never broken down into the senior population until a couple weeks ago. Some folks out of the University of Pittsburgh published this study. And what it basically shows is that on average, seniors visit physicians about 5, 6, 7, 8 times a year or so. But they visit their pharmacies about 12 to 14 times a year. A year. Basically, they see their pharmacies twice as often as they see their physician. So again, a good amount of face time. What this map is trying to show you is the darker the blue, the wider that disparity is between pharmacy visits and physician visits. So the point is they're going there anyway, right? What are the benefits and opportunities of clinical trials in community pharmacies? Highly accessible, right? It's in their neighborhood. transportation is less of an issue. Like we're in Los Angeles, transportation is always an issue. But at least local community pharmacies are often almost walkable. They're less likely, seniors in general, are less likely to want to use automated services. And we talk about Amazon and other big giants taking over pharmacy. Well, the reason why seniors probably are not going to flock to it is because, and anyone who's a pharmacist knows this, they struggle mightily with medication adherence, safety, appropriate use of devices. You can do a beautiful job of training a patient of any age on how to use a device, but chances are 6 weeks later they come back and they're missing one or two key steps in using that device, and even more so for the senior population. Believe it or not, pharmacies are very socially fulfilling for older patients. If any of you have hung around a pharmacy or worked in one like I have, they love to come and talk and visit with their favorite pharmacist. And it's just a place where they feel very comfortable. So again, they're going there anyway, they like going there. And there are probably more services that occur in pharmacies than many people know. You might already know that pharmacists do health screenings. Almost all do immunizations now. Some offer comprehensive medication management. Some can offer very extensive monitoring of medication safety and efficacy. And of course, they provide important education on the use of medications. And then data. If you work with a chain pharmacy, you get pretty robust data aggregated across the pharmacies, but you may not be aware that there are clinical documentation platforms that are commercially out there that now are able to aggregate clinical data from even independent pharmacies for the purposes of quality improvement and research. That combined with health plans is pretty robust data. And then we've spoken already many times about the importance of medication adherence. This is where community pharmacies thrive, right? They are able to markedly improve medication adherence. I provided several links to studies and reports that summarize that. One of those is that last one, Genoa Healthcare Pharmacy Services. These are pharmacies embedded within mental health clinics across the U.S., mainly on the East Coast, but they're now coming out here to the West Coast. And these are the variety of services they offer that help to improve medication adherence. I'm not going to read them through, but you can see there are a whole host of them. And what they've been able to do is remarkably improve medication possession ratios, or basically a marker of adherence, to numbers that are not common. If you hit 0.8 and above, you're doing really well. You can see that through Genoa Healthcare. They're hitting almost perfect adherence, at least in terms of the metric of medication possession ratios. They've also looked at their impact on hospitalizations, and I believe in their latest report, they've been able to cut hospitalizations by 40%. So certainly a very remarkable benefit of working with community pharmacies. For us, we have something called the California Right Meds Collaborative. It's a partnership between health plans and select community pharmacies that we train, coach, and drive quality improvement for in the delivery of comprehensive medication management. The way it works is the health plans are the ones identifying the high-risk patients. They stratify patients from high to low risk. We sort of co-develop this network of pharmacies geographically located and spread throughout their communities to provide easy access to their patients to receive these services. Health plans farm out those high-risk patients. We have various schools of pharmacies working with us to sort of coach and work with these groups of pharmacies to drive the better control and outcomes that we seek. And just so you know where we're headed with this, if you look down here, I don't know if you can see my pointer, but somewhere midway it says Pilot Program PDSA. We're in that phase of working with about 15 or so pharmacies now to develop the best practice model. And this is, I don't want to say it's adaptive research design, but it's adaptive modeling, right? We're sort of refining the best practice model in anticipation of that second to last line where we get the full rollout starting in late 2020. And I don't want to steal Dr. Blyler's thunder. She'll be speaking to you tomorrow about a very exciting project that we had a small part in. I was able to work with the late Dr. Ronald Victor in his pilot data that enabled him to get his NIH funding to publish this study in New England Journal of Medicine about managing hypertension through pharmacists in Black barber shops. And I just share it with you briefly because although the patient population served in this study was just under that senior cutoff, you can see in that third to the last line, I think what's really remarkable is the last row of this chart on the bottom. The average duration of years of patronage is about 12 years, better than just about any health plan I can think of. And even more remarkable is the frequency of haircuts every 2 weeks, sometimes more often. That's a lot of face time, a lot of contact time. And as Dr. Blyler will share, the integration with the primary care physician, with the medical home, and the ability to do point-of-care testing on site, basically chem panels, was remarkable and very effective in ensuring optimal safety. In fact, in this trial, 90% of Black men with hypertension out of control were able to reach goal working with a pharmacist versus 32% usual care. And as you can see, it doesn't really have anything to do with lack of insurance. Both the intervention and control group had similar levels of insurance.
Steve, this is your 2-minute warning.
Thank you. So the takeaways, perfect timing, just keep in mind, I think it's important to consider clinical trials that align with the elderly lifestyle. And I think I've provided some examples of that just now. PACE programs, great data, there's support and safety available. The community pharmacies, they offer a lot. I think that many people don't consider in terms of not just driving medication adherence, but the testing that they offer, the monitoring they offer, the accessibility. It's places where patients are really going. And whether you're talking about barbershops, wellness centers, bingo clubs, bridge clubs, I think it's important to think first of all about are these places where you're going to be able to get the data that you need, right? The other settings I've mentioned work quite well. The barbershop project worked well because of the way that Dr. Victor had set up his data collection structure. But the other element to really think about it, which I don't want to emphasize, is you want to avoid disrupting culture, right? Dr. Victor's fear when he went into the Black barbershops was, if we send a pharmacist in, is it going to change that social environment that's so important to the Black community? And the answer is it didn't. It actually worked very well. So just keep that in mind when you're thinking about which areas you want to venture into. And that's all I have. Thank you.